Susan Babirye, who is coming to present on exploring how the existing legal and policy frameworks on healthcare access for border residents in East Africa affect UHC and global health security agendas.
Good afternoon, ladies and gentlemen. My presentation is on the existing legal and policy frameworks on healthcare access for border residents in East Africa and how these affect, how the existing policy framework affect progress towards universal health coverage. My name is Susan Babirye from the School of Public Health. That is the outline of my presentation over there. But I would like to draw your attention to that picture. That picture is for Katuna border. Those of you who reside in East Africa know what is currently happening at that border. It's apparently closed due to political reasons. I want you to take a minute and imagine what is happening to the residents that used to access care on the opposite side of the border. I'll not take time to explain universal health coverage. It has been explained or talked about severally in this meeting. But I would like to take more attention, to take time to explain border residents. By border residents, we meant communities that reside along international borders. On one side of the road, say for example, they are in Uganda, but across it's Kenya or Rwanda or another country altogether. That is what I'll be referring to, or the people that stay in such settings are the ones that I'll be referring to as border residents. Again, speaker after speaker in this meeting, they have emphasized the fact that health is a fundamental human right. And again, they've mentioned the fact that universal health access seeks to see that access to health services is, health services can be accessed by everyone without any financial hardships. Despite those realities, despite the conversations around that, access to healthcare services remains a challenge for communities that reside along international borders in East Africa. The reason why it's particularly hard for these communities to access health services, it's because of their unique geographical position. They are placed at the periphery of the countries, normally underinvested and economically deprived. And yet, if you've ever visited those communities, you might find that the nearest health facility could be just across, which is in Kenya or the other country across the board. So what does that mean to them? Can they cross freely and access care? Or are there barriers that present in such situations? So in the era of universal health coverage or ensuring access for everyone, how are those communities going to be helped to navigate the barriers that present? I also want to explain the fact that some of the barriers are brought about by the different sovereignty that exists, and therefore those bring about different administrative, legal, regulatory frameworks, but as well as referral systems and even the currency, just being in one's next to the other country. On this other side, you have a different currencies, say for example, Uganda shillings. But on the other side, they are using Kenyan shillings or Tanzanian shillings or whatever it is. So when they present to the other facility, what are they going to use to pay for the services? At this point in time, opportunity exists in the current economic and political integration discourse in East Africa. It's a bit young, so we can take advantage of it now to push for a policy environment that will be favorable for the efforts that are triggered towards universal health coverage. This work is part of a big study that is exploring how to increase access for resident border communities residing in East Africa, access to health care. But in particular, what I'm going to present sought to explore the current legal and institutional frameworks and how those affect healthcare access for those communities. These communities are not homogeneous. Look at the one above, that is Lusomyo border. It's a rural setting, and indeed, you can see that it's at the periphery. That is River Kagera, demarcating Rwanda and Tanzania. Below is the most developed border that we have in East Africa, that is Busia border. But when you look at the community, there's only one infrastructure, one building that stands out of the rest. That is the picture of the borders that we have in terms of investment and location. How did we explore the legal and policy frameworks? We used two methods. The first method was the review of documents, and the other, key informant interviews with regional policymakers. The document review focused on international, regional treaties, conventions, as well as country-specific laws, regulations, guidelines, among others. So these documents were retrieved online, others from physical libraries of ministries, and others were suggested by the key informants that we interviewed. So the review team was a multidisciplinary team and reviewed all the documents, picking out clauses and specifications that affected cross-border access to health care. The parameters that guided data extraction and analysis included rights, entitlements, obligations, and institutional arrangements. In other words, the reviewers extracted rights, entitlements, state obligations, and institutional arrangements that related to access to health care. And the analysis was done manually. So to supplement the document review, we conducted key informant interviews with policymakers from the East African community and ex-health community to supplement what was coming out of the literature review. So this gave us views on the existing legal and policy frameworks and how these affected access to health care, specifically for the border populations. So the interviews were recorded, transcribed, and the analysis done manually. What do we see coming out in terms of the current legal and institutional frameworks? The first one, across the documents, we were able to pick out rights, entitlements, and state obligations. When you look at the documents that we reviewed, there were citizen rights and entitlements that were highlighted. These are rights to health care access. And when you look at the international documents, the conventions and treaties, they normally set a normative framework which guide the national level policy making. So besides having the convergence in terms of acknowledging or highlighting the right to health care, there was no explicit statement or specification that mentioned healthcare access for the border residents. In other words, the documents were silent when it comes to access to healthcare across the border. There's also no clarity as to whether the stated rights can be enjoyed beyond one's border. Yes, they say you have a right to health care, but can you exercise that right when you cross that road to the other side of the road in the next country? I've picked some clause article from the International Covenant on the Economic, Social, and Cultural Rights, and it states that state parties to the present covenant recognize the right of everyone to the enjoyment of the highest attainment standard of physical and mental health, an indication that it's in support of health care. Then when we talk to the key informant interviews, who are the policy makers? One of them mentioned that we do not have a law that formally allows people to move and access care across the borders. In other words, it's a concordancy that really the laws are there, but they are not explicit on accessing care across the border. The other finding that was picked from the documents was the institutional arrangements. We found things like standard travel documents mentioned in our legal and institutional frameworks, and those included border passes, passports, vaccination cards, among others. But there were also health financing mechanisms, say health insurance in some countries, and then other countries practiced free health care for all. So these drew the resident communities to the different countries for health care. However, they presented, in certain instances, these present as barriers to health care, because if you're not insured in country A, then even if you succeeded in crossing to that country, you won't be able to access care. As well as the documentations for travel. If you have them, they facilitate you to cross. But if you don't have them, you can't cross. Then we also picked some collaborative efforts from these documents. For example, the cooperation around joint investments for health, for example, the centers of excellence, and then a laboratory networking initiative. There are also some policy developments, especially the East African Community Protocol. It alludes to some bit of cooperation, especially amongst the East African countries, especially around disease surveillance. In conclusion, ladies and gentlemen, from our results, it's clear that there is consistency in terms of recognizing the right to health. However, the silence on specific benefits of non-citizens may hinder many to access health care in the region. As a recommendation, we need to take advantage of the current East African discourse to align what we have, to push for new policies to bridge out the gaps and create a favorable policy environment that will allow efforts towards universal health coverage to succeed. Thank you, ladies and gentlemen.